Okay, good evening students. Today I just want to tell you about the lumbar canal stenosis. First of all, lumbar canal stenosis is definition, complaints, investigations and management. Okay. First of all, definition. Definition is nothing but lumbar canal stenosis is the decrease in the lumbar canal diameter, that is anteroposterior diameter of the not only lumbar canal or the spinal canal stenosis, the spinal canal. Okay, there is decrease in the length of the anteroposterior diameter of the spinal canal. Okay, so general normal length is it is about 15 mm. When it in stenosis it is less than 10 mm. In severe stenosis it is less than 8 mm. Okay, so we can see spinal canal stenosis in various level, spine level. Okay, C spine, that is cervical vertebra, thoracic vertebra and lumbar vertebra. Most common is the lumbar canal stenosis, and we can also see it in the cervical spine. Thoracic is rare. Okay, and complaints. Coming to the complaints, patient complaints mainly pain. Okay, while walking or doing works or uphill, downhill, walking or doing some works. Okay, not only some works, and while sitting also some people complains of pain. Long standing works. Okay, while sitting or running, walking, whatever, and some complaints in severe cases rest pain also present, but there is a difference between whether it is ischemic claudication pain or uh, cauda equina claudication. Okay, in canal stenosis we see the cauda equina claudication, so we have to focus on the complaints of the patient, that is cauda equina claudication pain. It's mainly complains the pain or the buttocks. Okay, and the thigh region, that is also. So when these people uh, can what these people can be differentiated from the ischemic claudication pain. They complaints of pain over the legs. Okay, um, and in lumbar claudication pain, a patient may relieve from pain while sitting for some time. And claudication pain, we know there is lots of types, like uh, resting claudication or walking in relief. After walking, some people got relieved in claudication, some people got aggravated claudication while continuing walking, like that. Okay, so these are the differentiating features we have to use. There are lots of tests are also there. There is a stoop test. In stoop test, when patient while walking, when he when he got stooped, his pain got relieved, then the stoop test is positive. Okay, like in uphill stenosis, if there is a stenosis, patient may relieve his symptoms on climbing uphill, climbing. Okay, uphill, climbing upstairs or something, then he got relieved of pain and all. So these are the most common complaints of the patient. So age factors and gender factor is the males above 50 years of age, we generally encounter these symptoms. Okay, so investigations. Coming to the investigations, x-rays. In x-ray we have to see the spinal canal diameter, phases, laminar, interlaminar distance and all. So spinal canal stenosis, there is a reduction in the spinal canal anteroposterior diameter. So if it is less than 15 mm or it is about 10 mm or less than 10 mm, then we can conclude patient is suffering with spinal canal stenosis. It might be due to scoliosis, kyphosis or fluorosis, any fluorostic changes, or any fracture, due to fractures or any mass present or there. Okay, all these are causes related to the there is decrease in direction space of the spinal canal, and osteoarthritic changes are also, spondylosis changes are also the one of the cause of the reduction in the spinal canal diameter. Okay, so These are the complaints and investigations. And so initially we go for x-rays, and later on we will any neurological symptoms like any bladder complaints, urinary incontinence, or um if there is an urinary incontinence, rectal incontinence, is there any related like that, any complaints of paresthesia and all, then we will go for MRI scan. Okay, in order to rule out any neurological damage, because there is an reduction in nerve canal, nerve root canals are also space is also decreased, there is a compression over there. So involvement of all these things, so we have to investigate thoroughly. And we have to um, see initially, generally, we have to manage with the physiotherapy and NSAIDs. Okay, non-steroidal anti-inflammatory agents we generally used. Okay, and NSAIDs like NSAIDs like diclofenac and all tablets, and acetaminophen, acetaminophen, paracetamol. All these are we used for pain. Actually, pain management, initially we use opioids with analgesics. Opioids initially we use. Later then we have to add some steroids to it. But if it is a chronic pain, we will go for non-opioids. Okay, for non-opioids like if it is a chronic pain, then we prescribe what like non-opioids we have to give. So this is what physiotherapy, and then we will go for regular physiotherapy, ultrasonic therapies, heat therapies, and regular exercises. Okay, uh, they will help. And next we have to, you know if they initially we will according to the symptoms or patient complaints, or how it is, according to the pain grade and all, uh, you know uh, we will go for management. So some people are got relieved with medicines, definitely some people got relieved with the medicines. And if it is an in women, we will consider after 50-55 years of age, um, it definitely occurred, but not canal stenosis, but due to osteoporotic changes in females, their complaints may be mainly due to the osteoporotic changes and all that complaints, not stenotics, not stenotic changes and all. But we have to see. But in spondylosis changes due to sclerosis and osteophytic changes, there is a decrease of the spinal canal diameter and all. Okay, so these are the initial management. We will use belts, braces and all initially to manage. And always we suggest patients not to go very long journeys and all. And I ask the patient always to wear lumbar belts and corsets to wear, because it will helps to maintain the stability of the spine and all, while riding bikes and all. And see, if oral medication is not effective, then we will go for any epidural analgesics. So epidural analgesics, I mainly use the hydrocortisone 100 mcg, which is diluted with the 2% loxicod or lidocaine 2%. And we can give combinations also with chlorpheniramine and maleate. So these are, if you want to give epidural analgesia, you can give epidurally, or there are lots of types are also there, paraspinal or interspinal, or into the epidural space, or paraspinally we can give that analgesics in a, I mean, intraluminal or paraspinal we can give. Okay, these are the basic managements, like something like physiotherapy or analgesics, antipyrate, I mean analgesics, anesthetics and all, opioids, non-opioids, steroids. I always steroids for some time only, because it is depends upon the patient's immune status and also. But steroids almost it will helps to relieve symptoms very. I observed people, there is a reduction in symptoms while using steroids. The most commonly used steroid everyone is the prednisolone. So some people, all types of pains they got relieved, but don't prescribe it for long durations, or people according to the patient's immune status. We have to always check, prescribe the steroids and all. And coming to the surgical management, mainly laminectomy or discectomies or fusion. If there is discectomy in prolapse, I mean disc prolapse, or laminectomy, in order to in order to create the space. So, and if there is unnecessary loose bodies, I mean osteophytes, everything we have to remove, and just create some space for the spinal cord. The surgery is the main mode of the surgery is to um, relieve the compression. Okay, either it is compression of the nerve root canal, nerves roots, or spinal canal, spinal cord compression, in order to relieve spinal cord compression and all. Okay, so these are the surgical managements. So discectomy, see, there are through spinal canal there is at the level of, mainly the compression at the level of L4, that is cauda equina, where it got exists. This is the main reason. That is the main reason. That is cauda equina compression. Okay, at the level of L4, L5. So we have to do at the L4, L5 laminectomy, discectomy. Okay, and that means L4 laminectomy and L4, L5 in between. This is the discectomy will done to relieve cauda equina compression and all. Okay. Okay, guys, these are the main. Okay, these are the what I want to say. I explained it in a very brief manner. That is spinal canal stenosis. Okay, I hope it will help you. Thank you.